Good evening. I'm pleased to welcome everyone to the IMWG Conference Series, ASH17. This is in Atlanta, Georgia. You see a beautiful picture there of Atlanta, Georgia. The only correction I would make is that it has been snowing and extremely cold with freezing temperatures, which is quite a challenge for some of the logistics of ASH. But nonetheless, we're all glad to be here to hear a lot of new information and try to make sense of all of this to come up with the best treatment recommendations for our patients. I'm very pleased this evening to welcome two speakers who have joined us in the past. Very, very pleased to have these return speakers. Joe Mikhael from Mayo Clinic, Arizona. Welcome, Joe.
Thank you, Brian. It's great to be here.
Thank you. And Paul Richardson from the Dana-Farber Cancer Institute in Boston. So welcome again, Paul.
Oh, it's a pleasure, Brian. It's lovely to be here.
Very pleased to have you both. So for tonight, the topics are broken up into 6 segments. And this year, it is interesting that in each of these different areas, there were several interesting and sometimes quite important abstracts, updates. And so the idea would be to take a look at those, give some perspective, and see how they might change our day-to-day practice. So priorities for early disease, frontline options, the role of autologous stem cell transplant, maintenance recommendations, early relapse management, and then, of course, as always, we are interested in what are the new therapies. So if we start with the priorities for early disease, this year there were in fact a lot of analyses looking at what are the indicators of early disease progression, and tremendous interest in that. And so I will only show you a little bit of data. There was one quite interesting data set from the Mayo, Arizona, from Joe's colleagues, and quite interesting work where the team there have been quite involved in looking at MYC translocations, which seem to be especially important in early disease progression. And as you can see here, patients who did have early MYC translocations really were at much, much higher risk of early disease progression, really a dramatic lowering of the curve there. Now, another completely different approach, which has also been presented by Dr. Bruno Paiva from Pamplona in Spain, is starting to look at low levels of disease in the peripheral blood. And using the Euroflow combined Spanish method, the NGF method, which is sensitive at 10 to the minus 6, they have evaluated the blood for clonal plasma cells. So these curves here are looking at the presence or absence of clonal plasma cells in the blood in patients who have MGUS. And you can see here, if there are no clonal plasma cells in the blood, those low-risk MGUS patients remain stable. In the smoldering cases, if there are plasma cells in the blood or clonal plasma cells, then it really does increase the risk of early disease progression. Now, just to draw your attention, Sigurdur Kristinsson from Iceland, he gave an educational presentation about his iStop-MM project, which is one that's supported by the IMF Black Swan Research Initiative. It is, in fact, already the largest population-based study ever for the plasma cell disorders. The goal was to screen 148,000 Iceland population above the age of 40. And we were just in Iceland for the 1-year anniversary when we learned that 80,000 have already signed up, and with blood samples and testing ongoing for about half of those already. And so there will be a randomization to regular follow-up, some more intensive follow-up, and then an arm where intervention will be offered for those who meet the criteria for high-risk smoldering, for example. The diagnosis, the initial diagnosis is based on the presence of a monoclonal spike. One background element is that all of these patients have molecular sequencing data, which has been carried out by the DCODE facility in Reykjavik in Iceland. So a lot of information is going to come out of that, which will be certainly informative about the predictors of progression. So my question to you guys is, with this kind of information, some molecular information, of which there's a lot of different types, mutational load, various things that people have looked at, some cellular information with cells in the blood, which is also being looked at by several groups actually, and then population-based information. What do you foresee will be the best way to diagnose early disease? And so perhaps, Joe, you might want to start with this one.
Yeah, well, I mean, it's a great question. I think it's a really important question because so many of our patients are so anxiously waiting for each visit. Has my disease progressed? Has my disease progressed? And we've always had to wait on fairly archaic information, just an artificial rise in the monoclonal protein, or perhaps sadly the development of Crab criteria.
Yes, some bone
where a
lesions or
patient
something.
comes in with bone pain or kidney damage or something like that. So I think the drive to find the answer is critical. I'm not sure. I'm encouraged that we actually are finding multiple things. The MIC study that our group presented, I think, was very fascinating. Although it's a pretty small proportion of those who will have it. I mean, if I can't be a prophet, but if I were to predict it, it's kind of like saying, what are the measures that we would see that we're going to see a rise or a drop in the unemployment rate in the economy? We look at 5 or 6 or 10 different things, and I suspect that we'll add to our usual clinical questioning some kind of testing. The blood testing is the most attractive because it doesn't
would be a simpler
involve,
test.
Exactly, multiple bone marrows.
Right.
So I suspect that hopefully we can be better at that because there's still going to be such a significant group of patients who don't need intervention.
Right.
But it'd be nice to catch those patients before they're in trouble. As I often say, if someone's running towards a cliff, I don't have to wait till they're falling off the cliff to know they're in trouble.
Right.
But if the cliff is miles and miles away and they're going for a leisurely walk, we don't need to intervene earlier. So I think it's going to help us determine how fast a disease is growing and how far they are from the cliff.
Right. So Paul, what's your perspective about this?
I think Joe put it beautifully. I mean, I think the important point here is that, we've got multiple parameters that we can follow. And I agree completely that on the one hand, we have sort of hard benchline clinical criteria that we can use to sort of anchor our decision making. But at the same time, these new tools provide us with an ability to be that more, hopefully, have that much more foresight as to what might happen. And I completely agree with Joe that the essence of intervention is prevention, as it were, to further organ damage and or consequences thereon.
Certainly want to avoid that. That's the goal.
Exactly. And the whole point is that if we've got, as we now have with novel therapies, opportunities for therapeutic intervention that are so much better than they ever were, we've got the opportunity to actually employ or deploy these to help our patients. Now, in my group, we're very fortunate we have Irene Gabriel, my colleague, who's doing phenomenal work in precursor disease and MGUS and smoldering myeloma. And what she's showing very nicely is that you can actually intervene earlier with relatively non-toxic, simple treatments that can actually result in clinical benefit, we hope, recognizing there's work to do. But I agree with you, Joe. I particularly like your work with the c-MYC issue because, in a sense, that's a biological parameter that tells us, what we see as a sort of vanilla may not be. And clearly here, this is not vanilla, and we need to react to it. And I think that those kinds of observations are vital so that we can be that much more precise in what we do.
Right. So not quite there yet, but potential.
I couldn't agree more.
I think maybe just a final comment would be it emphasizes again, especially to so many listening today, that incredible need of doing that basic kind of work.
Yeah.
We need new drugs for myeloma. We need to do the large clinical trials, but understanding the mechanisms that underpin this disease are going to be critical for us to intervene at the right time.
Yes.
Right. And so obviously we are very excited to have the opportunity to be involved in the Iceland project, where we will learn a lot by tracking these patients carefully.
Yeah, I think that's phenomenal, Brian, and I think your initiative there really should be applauded. It's really something quite unprecedented, and I think that to see participation from the Icelandic population to such a degree.
They're so committed.
What a remarkable country.
They're on Facebook and encouraging each other to participate.
It's great. I mean, my simple point is, for people looking at, why? Well, why a lot? Because essentially they're committed in various other areas to sort of a stitch in time saves 9. And it's great to see that kind of participation from whole groups of people. It's wonderful.
Right. So we're going to move from this to something that you just touched on with Irene. what would be the management right now?
Right,
There are some management possibilities, and so we were quite fortunate this year at ASH to see presented a couple of quite important abstracts. So I'm just going to take us through slides from two of those important presentations. And so the first one is from the Spanish team led by Mary V. Mateos from the University of Salamanca, the CESAR trial. So obviously a very aggressive protocol for the treatment of high-risk smoldering myeloma, starting off with carfilzomib, lenalidomide, and dex, high-dose melphalan autologous stem cell transplant, 2 cycles of consolidation, and then 2 years of lenalidomide dexamethasone maintenance. So obviously this is the aggressive approach, and fortunately has been really tolerated reasonably well. And thus far, as far as the presentation, there are 35 patients who have gone through to the maintenance phase. So what have been the results? And I've just gone to the key endpoints here, which are 74% greater than CR, but I would draw attention to the blue bar at the bottom here, where 62% MRD negative at 10 to the minus 6. So really a substantial impact with achievement of that MRD level. And so this translates at this point into really excellent PFS and overall survival curves. And so this is obviously very important data to see what can be accomplished with this kind of a strategy. And there is an upcoming ASCENT trial, almost identical to this, where the induction will be daratumumab KRD. And so that will be starting in the first of the year. However, how about a more gentle approach? And we had the opportunity to see that at this year's ASH. And so this was the use of daratumumab monotherapy in smoldering myeloma. And the Centaurus trial had 3 arms, with the bottom one here being just basically the induction type of arm, and then an intense and long and less intense use of daratumumab. So 3 arms to assess the impact on an ongoing basis, or in this case, just with this initial cycle. And so the differences were seen in the overall survival. You can see here 56, 54, and then obviously much less with the short intense, as you would predict.
In response rate.
Response rate.
This is the response, excuse me.
Yes, no problem at all, yeah. Not at all.
Response rate,
Yeah,
yes, thank you, yes.
Yep.
And so this is obviously quite encouraging, but I think that this is, for me at least, somewhat sobering, is that in those 3 arms, you have obviously ongoing response in the continued therapy, but a rapid drop-off here with just that initial induction, as you might expect. So my question to you, you guys, is what do you think about this? What do you favor in terms? Really, I'm interested in the way that we should be exploring management in this setting.
Yes.
How do you view the cure approach, and how do you view the control approach? And so perhaps, Paul, you can tell us first what you think about this.
Well, I think thank you, Brian, for a fantastic summary of 2 very divergent approaches to a critical question. And I personally am struck by the fact that if you look at the continuous therapy with daratumumab compared to the transplant experience with intensive therapy pre and post, the results are very similar in terms of PFS outcome. And unfortunately, in Mary V's trial, as the slide showed, there was one catastrophic stroke.
Yeah, one patient had a stroke.
And died. And we know that there's a vascular toxicity to carfilzomib, which is being better understood. And in fact, there's some lovely work at the meeting that has teased this out.
Right.
So I think we have to be very careful.
Have to be careful, obviously.
And I think what we have to say, because arguably in a smoldering population, 1 death is 1 too many. In any population, one could argue it is. But the fact is, in this population, it's particularly true. I think that beautiful work, and I applaud the Spanish colleagues for doing such a careful and ambitious approach with, as you say so nicely on the slide, Brian, attempted cure. But I think that I'm struck by the quality of sorry, it was Craig Hofmeister who presented the Darrow paper. I'm struck
Correct.
by the quality of Craig's work. It really, and his colleagues, it really does show that with a non-toxic approach, because if you look at the grade 1, 2, and 3 toxicities,
Yeah, I didn't show that, but
it's really remarkable. I mean,
Yeah,
everything
all right.
was just here.
Yes. Oh, very
and
nice.
unfortunately, you know, when you look at, and Mariví did a beautiful job for preparation and very clear, when you looked at the grade 1, 2, 3s, they were out here.
Mm-hmm.
So the point is that, you know, and there was no quality of life report from Mariví's presentation yet. That will be essential. I was also struck by another thing, the MRD negativity.
Yes.
You know, 60%. That's interesting.
Mm-hmm.
But what's also interesting is when you look at some of the lovely work, for example, from Shaji with Ixazomib RD up front, in the high quality responses, the MRD negative rate is 80% without transplant. You know, that's this once a week
Right, right.
Ixazomib study that Shaji
Right.
updated at EHA. And in the same study set, you know, with the twice a week approach of Ixazomib with an all oral approach, we see the same without transplant.
Right.
So I think the question becomes, how much is enough?
Right, right.
And I think I applaud the
So-
Spanish group for the curative intent,
Absolutely.
but I think one has to be very careful because, you know, are we achieving a functional equivalent with antibody alone
Right.
or antibody immunomodulatory
Absolutely.
and
Absolutely.
a proteasome inhibitor that's just a pill once a week?
Yeah. So the ASCENT trial actually will start with DARA KRD without the transplant. So we'll have the data with DARA
Exactly.
KRD.
I think that's very important.
And then, so in that trial, it's going to be with and without the transplant, just to be aware. So how do you view this? Paul is expressing his concern about the intensity of this type of curative approach in the smoldering setting. But would you see any negatives to the simpler DARA approach?
Actually, I do. So I'll be a bit controversial.
Okay.
Is that I'm not convinced by the DARA work either. I mean, those
Okay,
response rates
right.
were much lower than we would ever want. And I guess my philosophical approach to it, Brian, Paul, is to say the approach that we took, would we change the criteria of myeloma from crab to slim crab?
Right.
We're
Where
drawing
you
that
changed
line.
it.
Well, I'm not sure. I didn't change it. I just named it. But that step was, I think, a very important step. And if I could be a little controversial for a moment, what I'd love to see is a day where we have MGUS here and myeloma here and no smoldering anymore.
Right.
Where we better draw the line and say, when someone crosses this line,
Right.
you need treatment. And that treatment is an evolving phenomenon. As Paul has said, we may or may not be doing transplants in the future. We may be including monoclonal antibodies
Right.
up front. But I worry about putting a separate category in the middle that
that's
we
fair.
kind of half treat. I'm not as worried about these DARA patients in the short term. Daratumab is a great drug, very
Yes,
well tolerated.
but in
I
the
worry,
longer
are we going to
term-
breed resistance? Are we not
Right, right,
treating
right.
the long term? So I'm almost in between these two, where I
Sure.
think one is too little,
And then-
you know, we're Goldilocks here, a little too
Right,
hot, a little too
too
cold,
cold,
maybe
exactly.
just right in the
So
middle.
I think that
I
the-
think if we go from,
Yes.
let's say, slim crab to slimmer crab or slimmest
Absolutely.
crab, who knows? But I think if we better define those points where we know someone is right on the verge of truly having myeloma and intervening the way we would treat everybody is probably safer than setting two standards.
So another point which I think might help us with this, in the Iceland study, what we are doing is actually giving KRD to the smoldering patients, and in a randomized fashion, KRD to the myeloma patients. So actually, we will be able to answer this point.
By comparing those two groups.
So we have the two groups. Does it actually make that extra difference to intervene that earlier? But we're using the same therapy, and so it hopefully get some information on that.
Yes, no, I agree with Joe that I think we have to be careful about this definition. I think
Yes.
in the future, actually, I do believe also that we will have true MGUS with some perhaps a high-risk MGUS for which there may be appropriate immunological interventions that are warranted. But in fact, ultimately, high-risk smoldering becomes active disease that we need to treat.
Absolutely.
And I think that what I'm struck by in our own experience, because we have a variety of approaches, and we've been using IMiD-based approaches, combining IMiD with Ixazomib under one of the studies that Irene is leading. And I'm very impressed, actually, with how well that's doing.
Good.
I'm also very impressed by how single-agent antibody is well tolerated over time. And I think you're right, Joe, that we certainly don't want to get into a situation of, betwixt and between. But at the same time, these efforts are very important because they juxtapose to what we've seen from our Spanish colleagues to say, well, you know, how much is enough?
Exactly.
And
exactly.
I think that, you know, we have to remember what we've learned now, and we are learning from the determination trial, which is the long-term consequences of high-dose melphalan.
Absolutely.
As our patients live 10, 15 years, the real spectre of secondary MDS AML is becoming more and more important.
We definitely need to be cognizant of that.
Exactly.
So thank you for that. Yeah. So.